Welcome everyone, Dr. Naveen here from UPSC MEDICO. In the UPSC CMS 2025 exam, from general surgery point of view, I could see that out of 40 questions, there were around 10 questions which were on the easier side. Now, 15 to 20 questions are of moderate level, and the 10 questions uh, which are out of box, like they are neither PYQs nor that easy to crack. So these uh, out of box 10 questions which are hard level, we will discuss them in detail. For remaining questions, we'll try to keep the discussion little brief with only key and little bit of explanation. Okay, let's begin with question number 1 from general surgery. The most common site of urethral opening in case of hypospadias. See, the topic hypospadias is important for any MCQ related exam because it is one of the most common urethral congenital abnormality, right? Common congenital abnormality of the urethra. So now the question is based on its urethral opening. As you look at this diagram, there are many sites at which, see, this is the typical urethral opening. It is the typical urethral opening. If there is failure of urethra to completely close on the ventral aspect, I'm talking about this is ventral aspect, the other side is dorsal aspect. So on the ventral aspect, if the urethra is not completely closed, okay, so this leads to hypospadias. The opposite is epispadias. Epispadias means if it is incompletely closed on the dorsal aspect. So this distinction is important. Hypospadias is on the ventral aspect. So when there is incomplete closure, the opening, instead of lying in the regular position, it can lie near the granular zone. We call it as a granular hypospadias, which is most common variant. We also have coronal near the corona. We also have penile, that is on the penis. We also have perineal. So perineal, penile or penile scrotal, coronal and granular. These are the 4 types of hypospadias. Among them, the most common is granular, and the granular, the ectopic urethral opening is placed on the glans penis, little proximal to the normal side. Coming back to the question, the most common site of urethral opening is just proximal to the glans. So this should be the correct answer here. Option 1. Now, which of the following about minimal access surgery are correct? See, there are 2 areas where I could see in UPSC CMS lot of questions coming. One area where they ask lot of questions is, what is this damage control surgery? Damage control surgery. One area not in UPSC CMS but in general everywhere is, what is this rapid sequence intubation? That is related to anesthesia. And one more area where questions will come is minimal access surgery. See, minimal access surgery is nothing but kind of laparoscopy, right? An indirect name. Apart from laparoscopy, there are other surgeries as well. See, the biggest advantage, see, minimal access surgery is a product of modern technology. Modern technology, that is, we have so many modern instruments, modern surgical innovations happening in the field of general surgery, which gave rise to this new branch known as minimal access surgery. The biggest advantages of minimal access surgery is you're using laparoscopes. That means you will have decreased wound size in general. So we are not doing laparotomy or a big opening in the abdomen or somewhere else. And also it reduces risk of infection. It also reduces risk of dehiscence of the wound or wound dehiscence. There is one more question on wound dehiscence in this UPSC CMS itself. So minimal access surgery decreases the risk of wound dehiscence, and also it decreases risk of bleeding. It also decreases risk of herniation. Look at all these are the disadvantages of invasive open surgery, but minimal access surgery will decrease all these things. And also, very importantly, it improves mobility. The patient can be sent home. Sometimes even OPD surgeries are performed because of minimal access, right? And also, apart from that, it increases or it improves visualization because of the camera ports we use. Okay, so these are the few advantages of minimal access surgery. Now coming back to the question, as you could see, which of the following about minimal access surgery are correct? decreased intraoperative heat loss, improved visualization. So this is correct. Improved visualization. Increased chances of herniation, wrong. What does it do? It decreases chances of herniation. So option 3 is absolutely wrong. Now improved mobility, we already covered. Right? So what is this decreased intraoperative heat loss? Right? So what happens in minimal access surgery is that when the surgeries are performed, because of the minimal procedures, the surgery is over quickly. So during the surgeries, overall intraoperative heat loss is low. And there are some techniques during minimal access surgery which will also reduce that. So that is beyond scope of our discussion. But in a way, this is also true. But straight away, increased chances of herniation is false. So the correct answer here is 1, 2, 4 for this particular question. Now next question is maximum safe dose for lignocaine without adrenaline as a local anesthetic drug. Now if I ask you, you need to understand a concept. Why do we add lidocaine plus adrenaline together? What is the significance of adding adrenaline to an anesthetic agent? When we add adrenaline to a local anesthetic solution, it prolongs duration of action. This is one thing. And it will hasten onset of action. That means you will see a quicker action because of using a local anesthetic. And also, very importantly, it permits higher dose limit. Keep a note of this point, because when I'm adding adrenaline to any local anesthetic agent, it is allowing me to use higher dose limit. That means if I take lignocaine, if I use it without adrenaline, the maximum dose I can use is only 3 mg per kg. But if I add adrenaline, then I can increase it to 7 mg per kg. So the correct answer is 3 mg, because they are asking lignocaine as a local anesthetic agent. 3 is a little bit of memory based question, I think a little tricky, but they're asking questions like this in UPSC CMS. It's a norm. There is one important table in Bailey and Love from where this is taken. So I want to add one point here. So whenever you see general surgery, anesthesia per se is included in general surgery, and 1 to 2 questions every year come in UPSC CMS from anesthesia part. And this anesthesia, you don't have to refer to any standard anesthesia book. The anesthesia part which is mentioned in the Bailey and Love, from that only, from high yield tables they are asking questions. So that's why I tried to cover in regular UPSC CMS course of UPSC MEDICO. I tried to cover all the high yield tables so that it will be easy for you. Like if you consider it as a high yield table from only Bailey and Love, so you're not going to read the whole anesthesia, right? You're only going to focus on some of the important topics of anesthesia. Now, just for the sake of completion, you know the dosage of lidocaine. Now, apart from the lidocaine, there are other anesthetics like bupivacaine. The maximum dosage for bupivacaine is 2 mg per kg. We have prilocaine. Even prilocaine also, we use either adrenaline or with or without adrenaline. With adrenaline, the maximum dose limit is 7 mg per kg. Without adrenaline, the maximum safe dose for prilocaine is 6 mg per kg. These are the only two drugs, lignocaine and prilocaine are the only two drugs wherein we use with or without or with adrenaline. Okay, without or with adrenaline. Now there are some other drugs also like ropivacaine, which is a local anesthetic agent. Again, 3 to 4 mg per kg. Now finally, we have levobupivacaine, which is also 2 mg per kg. So overall, what I could see is, in a way, 2 mg per kg is the dose, starting dose for most of the local anesthetics. The maximum dose is going up to 9 mg per kg. So overall 2 mg per kg is given by both bupivacaine and levobupivacaine. Bupivacaine and levobupivacaine. From PG point of view, bupivacaine is important because it is associated with cardiotoxicity. One question which was commonly asked in entrance examinations, right? Apart from that, you have 3 to 4 mg per kg. 3 mg per kg, just remember 3 mg per kg you have lignocaine without adrenaline, and also you have ropivacaine. That's it, ropivacaine. Now you have 6 to 7 mg per kg. Remember, there are two things. One is prilocaine without adrenaline, and lignocaine with adrenaline, and finally NMG, as I said, this is again prilocaine with adrenaline. Okay, so these are the few drugs. Maybe in future this question might get repeated, but as a conceptual doctor, if you want to know the concept, you need to understand why do we add adrenaline to any local anesthetic agent. We add it to hasten the process of action, prolong its duration of action, and also it allows to use higher dose limit, right? This next question, this is general surgery question about lymphedema. How a patient with lymphedema presents to the clinic is the question. So there are many symptoms which are frequently experienced by patients with lymphedema. One common symptom which we all know is, first and foremost, we see swelling. In a patient of lymphedema. This is one thing. And now, apart from that, the patient will also complain of constant dull ache-like sensation, and patient will also complain of burning sensation. So swelling is correct, burning sensation is correct. Because of the lymph stasis, patient will also complain of cramps. So cramps is also correct. Now, this lymphedematic limb or edematic limb, because of the lymph obstruction, it is sensitive to heat. No about cold, it is sensitive to heat. Okay, if it is heat, intolerance to heat, that could have been a right answer. So because this is wrong, the correct option here is 1, 2 and 4. So key answer 1, right? Apart from that, general tiredness, pins and needle sensation, skin problems, immobility, backache, athlete's foot, these are all the various symptoms with which lymphedema presents. Okay, so we're done with this question. Let's go to the next question. Now, which of the following are the malignancies associated with lymphedema? They are continuing. See, the UPSC asks these kind of repeat questions from the same topic within an exam. If you know lymphedema, 2 questions. Now, when we talk about lymphedema, if you remember CA breast, post mastectomy, the commonest complication which develops is lymphedema, and this lymphedema, if it is chronic, the patient will land into a cancer. There is a specific syndrome for that. The cancer which develops is lymphangiosarcoma, and the name for this cancer, this is very important, many times questions are coming in the entrance examinations, that is Stewart-Trevis syndrome. Okay, Stewart-Trevis syndrome, you need to know this. Stewart-Trevis syndrome is lymphangiosarcoma. So any long-standing lymphedema will develop into lymphangiosarcoma. Apart from that, it is also associated with Kaposis sarcoma. It is also associated with squamous cell carcinoma, and even malignant melanoma can occur in this. Even basal cell carcinoma can occur in. Leukemia is out of question. With common sense, you can rule it out, right? How come leukemia occurs in lymph, right? Lymph is different, blood is different. Leukemia is a blood cancer. If you have committed mistake in this question, like it is like a blunder, right? So the correct answer here is 1, 2 and 3. Option 1. Now next question is, which of the following are the techniques commonly used to close raw area after excision of a pilonidal sinus? See, from the anal canal, rectum and anal canal diseases, there are many diseases which are important. One area where questions come is hemorrhoids, and they have now asked a question on pilonidal sinus. I have discussed this topic in greater detail for UPSC Medical Science optional students, IAS, IPS students, because every year the UPSC board is asking one or the other question in this area. One area where lot of questions come is the diseases, surgical disorders of rectum and anal canal. The list is exhaustive here. Similar way, there is one area questions come, that is gallbladder and bile duct. Lot of diseases are there. Once they'll ask extrahepatic biliary atresia. Next they'll ask like in this exam they have asked a question on Budd-Chiari syndrome, right? So these are the two areas which are gray zones. Anything can be asked both in CMS and CSC examinations. Now coming back to the rectum anal canal, the question of choice here is pilonidal sinus. Now when we treat this case of pilonidal sinus, there are various surgeries available. Okay, one surgical technique which is available is, I am talking about the surgical methods. I am talking about surgical methods available to treat pilonidal sinus. So one surgical method is just lay open all tracts. Okay, lay open all tracts. You can either do, or without even that, you can either do marsupialization or without marsupialization. You can lay open all the tracts of pilonidal tract, or without laying open. Instead of just laying open, you can even go for excision of all tracts. You can either close or you can leave it open. That is, primary closure can be done or cannot be done. This is excision of all tracts. You can either lay open all the tracts or you can completely excise the sinus. Now there is one way wherein you can excise all the tracts. You can excise all the tracts of pilonidal sinus. Then you can close them not by primary closure, but you use different methods. One method is Limburg procedure. Other is Z-plasty, and the other procedure is Cary-Dakis procedure. See, in general surgery, any surgical procedure with a special name is important for MCQs. There are three techniques by which pilonidal sinus is completely excised and closed with special procedures just to avoid a midline wound. These are Limburg procedure, Z-plasty, and Cary-Dakis procedure. There is one more procedure which is done, that is Bascom's procedure. Just remember, I am not detailing it out because it is taking a lot of time to discuss all these things in greater detail. But you need to know the names, that Bascom's procedure is also a surgical procedure which is done in case of pilonidal sinus. Now what are the options? You see, Limburg procedure is there, Z-plasty is there, Cary-Dakis procedure. Don't get confused with YV-plasty. See, YV-plasty is a wrong option. It is a reconstructive surgical technique. Where we make a Y-shape incision, then we close it in a V shape. This is used in correction of stenotic areas, and this is not at all related to pilonidal sinus, because pilonidal sinus is a sinus, it is not stenosis. So VY-plasty is wrong. Limburg procedure, Z-plasty, and Cary-Dakis procedure is right. The correct answer is 1, 3 and 4. Where is 1, 3 and 4? So option 3 is the correct answer. So this is question on pilonidal sinus. Now I'm not happy with this question for various reasons, because see, like post MBBS, before doing my MD in medicine, I worked in a nuclear medicine PET CT center as a medical officer. There used to come some cancer patients. I used to take their history and make them ready for the scans. We'll check for anaphylactic reactions. We treat if there is an emergency. During that procedure, we used to get a lot of cases for breast cancer. See, case of lump in breast. Now, there are various ways. We have triple assessment, which is very important for our exam point of view, where we ask about history and physical examination, plus we go for imaging, either ultrasound or mammogram, plus we go for biopsy. Biopsy can be FNAC or biopsy. So these are the triple assessment which has a positive predictive value more than 99.9%, right? But you know what? In general, if there is a suspicion of malignancy, if it is confirmed that it is CA breast cancer, the modern surgical oncologists, they directly refer a case to PET CT, because PET CT will help in knowing about the metastasis. It is all about understanding whether metastasis is there or not. If there is metastasis, the prognosis is poor. If there is lymph node involvement, the prognosis is poor. So instead of going for T&M staging, nowadays the current surgical oncologists, they are straight away using PET CT to identify mets. So T&M staging per se is obsolete, and the modern surgeons are not using it. The same statement is given in Bailey and Love. The same statement is given in Bailey and Love. Bailey and Love says that for the current era, the classical staging, okay, is used less often, because now we are looking at, apart from this, we are also looking at biological variables. We are looking at the luminal classification, luminal A, B, HER2 new positive or triple negative or Claudin type. So molecular profiling is gaining more importance. So that's the reason the older TNM system is losing its significance. And in the latest edition of Bailey and Love, they haven't given this TNM staging at all. That's why I'm not teaching this to students as well. Because CA cervix, TNM staging is important. They'll ask it. CA colon, they'll ask. Any intestinal malignancy, chances of asking TNM. Even CA endometrium, they can ask. CA endometrium. Gynecological malignancies, TNM staging is important. But breast carcinoma, not that important. But suddenly the question has come up. So I think there's no escape for us. We have to learn it. So just if you know the T staging, TX means cannot be assessed. I'll keep it very simple. T1 means 2 centimeter are less in dimension. T2 means 2 to 5 centimeter in greater dimension. You have to take which dimension is greater. That means if the lump is 3 into 4 centimeters, you have to take 4 centimeters as greater dimension. Okay. Now T3 is more than 5 centimeters and T4 have various segments. It's not about size. You have T4A, 4B and 4C and 4D. During my MBBS days, when I am writing entrance examinations, they are fond of asking this T4D. T4D is inflammatory carcinoma. Very dangerous. Inflammatory carcinoma, more or less seen in pregnant women. Okay. Mastitis carcinomatosis. T4A is extension to chest wall. If the tumor is more than 5 centimeters and it is extending to any chest wall, ribs, etc. or muscles, then T4B is the classic extension to skin, which leads to pseudo-orange appearance. Okay, pseudo-orange appearance. These are the two things. If there is both extension to chest wall and extension to skin, then it is T4C. Then T4D is inflammatory carcinoma. T0 is no evidence of tumor. TI is carcinoma in situ. TX, tumor cannot be assessed. This is T staging. N staging, N0, no nodal mets. Okay. NX means nodes cannot be assessed. N1 means metastasis to ipsilateral axillary lymph nodes. Ipsilaterally axillary lymph nodes. N2 means metastasis to ipsilaterally axillary lymph nodes only. But in N1, these lymph nodes are mobile. In N2, there are segments like 2A. That means they are fixed to one another. It is again ipsilateral axillary lymph node, but they are fixed to one another. N2B, even ipsilateral internal mammary nodes are also involved here. Okay. Now N3 means metastasis to infraclavicular lymph node. I am only talking about ipsilateral infraclavicular lymph node. N3B, this is infraclavicular lymph node is N3A. N3B is internal mammary nodes plus axillary lymph nodes. If both are involved, internal mammary and axillary lymph node, then it is N3B. Now N3C is involvement of the supraclavicular lymph nodes. Now metastatic MX cannot be assessed. M0 means no mets. M1 means mets. Right? And the most common location where CA breast metastasizes is bone. There is one more question in the same exam on this. We will come back to that discussion later. But metastasis, if present, will put TNM staging as M1. Coming back to the question, let me read the question for you. 45-year-old lady with history of painless lump, right breast, 1 month. Examination hard lump, 3 to 4 centimeters. So I would go with greater dimension as 4 centimeters, which will put T staging as T2. In the upper outer quadrant and not fixed to the skin or underlying structures. That means it rules out the T3 or T4 staging. The axilla reveals firm mobile lymph nodes. That means firm mobile lymph nodes. I am talking about N1. And rest of the systemic examination is normal. He haven't mentioned any metastatic Verpub. So I want to put as MX. So my clinical staging is C, T2, N1, MX. So the correct answer here is option 2. It's as simple as that. But they shouldn't ask TNM staging of CA breast because in clinical practice they're not using it. Now coming back to next question, which one of the following is considered the gold standard for diagnosis of, see, The most common esophageal motility disorder which is commonly asked in the exam is achalasia cardia, and the gold standard for diagnosis of achalasia cardia is high resolution manometry. As simple as that. Okay, barium swallow, bird beak appearance is there, but students tend to confuse that because bird beak appearance is there, that is gold standard, but that's not the case. High resolution manometry is the gold standard for diagnosis of achalasia cardia, or in general the diagnosis of esophageal motility disorders. Now, which of the following are considered etiological factors for adenocarcinoma esophagus? See, when you look at CA esophagus, there are two types of cancers that you see. Squamous cell carcinoma in poor countries, adenocarcinoma in rich countries or developed countries. Nowadays, the incidence of adenocarcinoma is increasing. There are three risk factors, important risk factors for adenocarcinoma. One is Barrett's esophagus. Okay, that is intestinal metaplasia which predisposes to adenocarcinoma, and this Barrett's esophagus is a consequence of gastroesophageal reflux disease. These are the two important things. And this GERD develops because of obesity. That's the reason in modern countries or developed countries, obesity is prevailing, which leads to GERD, which in turn leads to Barrett's esophagus, which in turn causes adenocarcinoma. As simple as that. But squamous cell carcinoma, the two important risk factors. One is alcohol and the other is smoking, and the geographical areas as well, but these two are important. So when you look at these options, I think first is correct, gastroesophageal is correct, obesity is correct. I think alcohol will go for squamous cell carcinoma. Because you have to choose three options, I would like to go for 1, 2, 3 as a correct answer for this particular question. Right, we're done with this question. Let's go to the next question. Now, consider the following statements regarding Plummer-Vinson syndrome. See, the Plummer-Vinson syndrome, I got it a little difficult to search for answer from standard textbooks because I had to refer to both Bailey and Love and Manipal as well. Because in Plummer-Vinson syndrome in Bailey and Love is given in bits and places at places, like different places. In one area, they talk about when they teach you about Plummer-Vinson syndrome, one area they are covering about just sideropenia. What is sideropenia? Sideropenia means there is iron deficiency, but no anemia. No anemia. So in this patient, they have siderophasic dysphagia. Siderophasic dysphagia. They're not presenting with iron deficiency anemia. They'll have siderophasic dysphagia. Sideropenia means iron deficiency in absence of anemia. This also leads to, sideropenia also leads to development of risk of oral cancer. There is a risk of oral cancer. This is one thing. This is one area where it is covered. Apart from that, there is one key feature, that is post-cricoid esophageal webs. So what do you see here? One feature is siderophagic dysphagia, that is there is sideropenia, sometimes iron deficiency is there with anemia or without anemia. There is predisposition to oral cancer. There is also post-cricoid esophageal webs. Which causes siderophasic dysphagia. So all these things put together, they will call this condition as, you can either call it as Plummer-Vinson syndrome. There are various names for this particular syndrome. Plummer-Vinson syndrome, or you can call it as Patterson-Kelly syndrome, or you can call it as Patterson-Kelly-Brown syndrome, or you can even call it as siderophasic dysphagia. Sideropenic dysphagia. I'm sorry. Right? These are the important things about Plummer-Vinson syndrome. So you will see cervical esophageal web, right? You will sometimes see iron deficiency with anemia or without anemia. And yes, there is dysphagia. It's a rare disease, I agree. It mainly affects middle-aged women. Yes, that too. There is a specific area or region where the women are affected in this particular condition. The particular area women are actually affected. So any middle-aged woman is a risk factor here. And there is predisposition to post-cricoid and cervical esophageal cancer. Yes. Treatment is usually surgical. No, you can give medical treatment. Iron supplements can be given. In these cases. Okay, this iron supplements reduces epithelial atrophy and it reduces the risk of malignant transformation. Okay, the other features which can be seen in these cases are koilonychia, The other features which can be seen in these cases are chelosis. Okay, and the other features which can be seen in this particular disease are, apart from the koilonychia, apart from the chelosis, there is angular stomatitis as well. Angular stomatitis, a little complicated question. I told you there are 10 questions which are little out of the web. This is one area, because treatment is usually iron supplements, reassurance, but if that doesn't respond, we can go for regular dilatation by gum elastic bogies, which is rarely done. Surgical correction is not needed in case of Plummer-Vinson syndrome. So I would like to go for option 1, 2 and 3. So option 4 is correct in this case. The next question is vibration white finger. Okay, vibration white finger you might confuse with lymphedema, or you might confuse with acrocyanosis or vasculitis or Burgess disease, that is finger might become white because of the vascular occlusion. These are all wrong. We have Raynaud's disease, which is idiopathic. Similar picture, but very little severe condition is seen because of secondary causes, and among the secondary causes, one of the important causes are collagen vascular diseases like SLE and all, right? So there also you will see this disease. Then we call it as Raynaud's syndrome, not disease. Raynaud's syndrome is secondary. Raynaud's disease is idiopathic. We don't know why it comes. The same Raynaud's syndrome is also seen as an occupational disease. People who use vibrating tools, they will develop this vibration white finger, with this Raynaud's syndrome. Okay, so vibration white finger is Raynaud's syndrome, a secondary cause seen in people who use vibrating tools in industrial disease. So we call it as a vibration white finger. So we tell patients to avoid vibrating tools if they develop this vibration white finger, right? So the correct answer here is Raynaud's syndrome, which is vibration white finger. Now, which of the following are criteria for cancer screening? This is again actually question from PSM, but because it is related to cancer of GS, they have integrated it. So screening test should be sensitive and specific. Agree? Actually, for cancer screening, because if you can detect cancer early, first you need a screening test with high sensitivity. Even if it is of low specificity, it is fine. Because diagnosing cancer early will change the course of the disease. Like, you can treat him. Okay, so screening test should be high sensitive. If it is low specific also, it's fine. If you are screening for diabetes, there is already a load of diabetes in the Indian health system. If you keep on diagnosing more and more cases with high sensitivity, then it is risk. So for these, any screening test which is used for a disease with large burden on the health system, you have to choose high specificity and low sensitivity kind of screening test. Okay, just for the general information, I told you these points. Just ignore for them now. Coming back to the question under discussion, now I'm talking about a disease or a screening disease. A disease, there is a specific criteria. We call this criteria as WHO Wilson and Zanger criteria, which is laid down in 1968. There are 10 important classic criteria. I will not discuss this 10 here. It's a time consuming process, but what you need to know is, whenever you have to use any of the screening test, it should cater to an important health problem. Okay, and it should be sensitive and specific. It should be acceptable to the screened population, and it should be an important health problem. The disease, if it is uncommon, will not use it. And the disease should be able to recognize it in an early age so that you can initiate the treatment. What is the point of diagnosing prostatic carcinoma? It's already it develops very late, after 90 years. most of the times we don't even treat that particular disease. What is the point of screening for that disease, right? So it should be very common disease. It should be recognizable at an early stage so that you can initiate the treatment. Early stage initiation, we call it as yield of a test. Yield. Okay. In the screening, the yield is also important. Right? So I would like to go for options 1, 2 and 4 here. 1, 2 and 4, option 2. Option 3 is wrong because the disease should be common. Common disease. It should be like a common disease seen in the surroundings, right? Done. Now, a 45-year-old lady presents with complaints of fatigue, muscle weakness, bilateral multiple renal stones, and elevated serum calcium. So, you have hypocalcemia, you have muscle weakness or fatigue, and you have bilateral multiple renal stones. Pains, stones, groans. What is this? Primary hyperparathyroidism. Whenever you see any hyperparathyroidism, the first test we do is we check for PTH levels. If PTH levels are high, we'll confirm the disease. Then we have to localize the source of PTH. That is, where is this parathyroid adenoma located? It can be anywhere in the body, right? So for that reason, we do a nuclear medicine scan known as system EB scan. Okay, known as system EB scan. So this is how you approach a case of primary hyperparathyroidism. Now in the Bayesian doubts, it's clearly mentioned the best investigation for localization of adenoma is system EB scan. So my answer is option 2. Right? But if the same question, what is the next best investigation required to arrive to a diagnosis? If they mention PTH assay, go for it. Because first you have to confirm the diagnosis. Then system EB scan is for localization. Next step is localization. Right? Please, next time they might ask the same question in a twisty way. So you have to be very careful. Now, which of the following are the etiological factors associated with communicating hydrocephalus? See, when we talk about hydrocephalus, there are two entities. One is non-communicating, the other is communicating. Now, it is very important to understand the differentiation because if it is non-communicating or obstructive, it is dangerous. You cannot perform lumbar puncture here and you cannot immediately medical advice is not needed. You have to go for surgical decompression here. Immediately you have to go for surgical. But communicating hydrocephalus is because of decreased reabsorption of CSF. It is not because of obstruction. It is decreased reabsorption of CSF. That means you can wait, you can do lumbar puncture for diagnosis. You can even go for medical management as well. So when I talk about communicating hydrocephalus, there are etiological factors for this particular communicating hydrocephalus. Right? So what is the etiology of communicating hydrocephalus? It can be post-hemorrhagic. It can be because of CSF infection which can be diagnosed by lumbar puncture, or it can be because of raised CSF protein. The lesions within the ventricle, they lead to obstructive hydrocephalus. If there is any lesion in this ventricle, it causes obstruction, right? So this is wrong. So the correct answer is 1, 3 and 4. Where is 1, 3 and 4? So option 3 is the right answer for this particular question. Right? Next question. Shall we go to the next question? Yeah. Which of the following statements are correct regarding a brain abscess? If you think that I'm going too fast, in the YouTube you can use options like 0.5x or 0.7x if possible. Okay. Now, which of the following statements are correct regarding a brain abscess? So this question is little tricky because everything related to brain abscess you have to by heart memorize from the Bayesian law. Okay. But we'll try to apply some common sense in solving these questions. First and foremost, if you see any abscess, okay, why abscess develops within the brain, right? It can be hematogenous. It can be hematogenous. I'm not ruling out the option of hematogenous. Abscess can also, like if there is a brain here, right? There is a brain which is covered by the skull. Now, it also gets blood supply from the vascular system. So the infection can be hematogenous. Infection can be because of the opening of the skull. So abscess arises when brain is exposed directly as a result of fracture or infection of air sinus also. So agree. You know, one of the most common complication of chronic sinusitis or CSOM, that is chronic suppurative otitis media, any sinus infection, is abscess. So abscess can result from either fracture or infection of air sinus. So answer is correct. Presenting features are low grade fever, confusion, seizures, focal deficits. Yes, it can be a possibility, right? Now MRI with contrast is the initial imaging modality of choice. Brain abscess, there is a typical CT scan feature that you see in brain abscess. So there is a classic appearance of smooth walled, well defined ring enhancing mass lesion. So you don't have to go for that, just CT is enough. No need to go for MRI with contrast in these cases. Now etiology is most common is bacterial infection, can be aerobic and anaerobic, but in immunosuppressed protozoa can be seen, virus can be seen, fungal infections can also be seen. So option 4 is also right. So my correct answer is 1, 2 and 4. Okay, option 3 is wrong because the initial imaging modality of choice is CT. This is CECT, so that you can see ring enhancing lesion. What is the most common type of tumor of vermiform appendix? I want you to put this under the controversial stuff, because if you open any AI platform and ask answer, they will say carcinoid tumor. If you open Manipal, it will also say carcinoid tumor. But my answer is epithelial tumor. My reference is Bayesian law, because from that most of the questions are coming. Why not carcinoid tumor? Why they keep on repeating the same question? What is the most common type of tumor of vermiform appendix in every competitive exam? Because they know that we are committing mistake every year. Okay, so very clearly in Bayesian law, it is mentioned that I will give you the statement. Okay, most tumors, I'll write it down so that you will not forget. Most tumors affecting vermiform appendix, they may be classified as either carcinoid, or they may be classified as either epithelial, carcinoid or epithelial. Now, this later group, epithelial, is approximately seen in 3/4 of the cases, whereas 1/4 of the cases it is carcinoid. I am talking about pathological examination of appendicectomy specimens. When pathological examination is done, epithelial neoplasms are almost found in, okay, almost like if you take 100 appendicectomy specimens, out of them, now 1000 appendicectomy specimens, out of them 100 will have appendix tumors. Out of this 100, when you examine further, 0.6% of them are epithelial cancers, and very negligible, almost 0.01%, because they haven't given the percentage in the Bayesian law, but they are saying that 1 in 300 to 400 cases, that is 1 in 300 to 400 cases, you will see this. So it's clearly mentioned that most tumors involving the appendix may be classified as either carcinoid or epithelial, but epithelial is approximately 3/4 of all cases. That means the most common type of tumor of vermiform appendix is epithelial tumor. This is my answer. I will wait for the key to be released and I'll check with the K. If they're still going for carcinoid tumor, I will recorrect it and I'll post it in our social groups, and also I'll let it know to all my course students, right? So, but for now, my key is epithelial tumor. May be controversial, but my key is epithelial tumor as per Bayesian law, right? Shall we move on to the next question? Right. Now, earliest specific cystoscopic appearance of bilharzial cystitis. So, bilharziasis is because of schistosoma hematobium. This hematobium has special predilection for venous plexus, that is vesical venous plexus. That's why it's go to the bladder. It causes bilharzial cystitis. But when you do cystoscopy to look for microscopic appearance, like how it looks, when you want to examine, not microscopic, cystoscopic appearance, it has characteristic appearance. Okay, it has characteristic appearance. So what are the characteristic cystoscopic appearances? One is it can form pseudotubercles. So these pseudotubercles is earliest specific appearance of the disease. Earliest specific appearance of disease. This is the question that they're asking. What is the earliest specific cystoscopic appearance of bilharzia? It's given in Bailey and Lau that it is pseudotubercles. The correct answer is answer C. Apart from this, you will also see nodules. You will also see sandy patches. You will also see ulceration in cystoscopy. You will also see the fibrosis in cystoscopy. Granulomas are also possible in cystoscopy. Papillomas can also be seen, and we all know cystosoma infection is a microbial carcinogen. That means even carcinoma can be a possibility. Bladder carcinoma can arise because of bilharziasis, right? Microbial carcinogenesis, carcinoma. So pseudotubercles, nodules, sandy patches, ulceration, granuloma, fibrosis, papilloma, everything is seen. But earliest specific appearance of disease is pseudotubercles in case of bilharzial cystitis. Now, neurosurgery question, pediatric neurosurgery. What is craniosynostosis? Craniosynostosis is premature fusion of one or more cranial sutures. So, how many cranial sutures do we have in the head, in the skull? We have coronal sutures. We have lambdoidal sutures. We have squamous cell sutures. We have sagittal sutures. You know, they all fuse between 6 to 12 months of age. Whereas frontal suture, it fuses later, in later part of life, very late. If there is premature fusion of these, that means if coronal, lambdoidal, squamous, sagittal and frontal, if they are fusing before their actual time, then it leads to craniosynostosis. Now when they fuse prematurely, they actually prevent growth perpendicular to the suture. Okay? Perpendicular to the suture, not in the parallel lines to the suture. That means, see this? Because of that, if there is a sagittal suture involvement, okay, it leads to scaphocephaly. This is sagittal suture involved. So there is preventing growth perpendicular to the suture. Okay. Similarly, brachycephaly due to involvement of coronal suture. Scaphocephaly because of involvement of sagittal suture. Trigonocephaly because of involvement of metopic suture. Plagiocephaly can be anterior and posterior because of involvement of lambdoid suture. Right? So these are if all sutures are involved, it leads to microcephaly. Okay, so briefly, this is what you need to know about craniosynostosis, and the correct answer is option 2 here. It is premature fusion of one or more. One suture, if it is closed, it is called simple craniosynostosis. If one or more is involved, we call it as a complex one. Okay. Now this question we already discussed, that 60-year-old female, pain in her back. She was found to have lytic lesions in the vertebrae. So there is an osteolytic bony lesions in 60-year-old female. So the most common cancer which metastasizes to bone is breast cancer. So I would be screening her to detect the primary cause of lesions. So I would screen for breast. I would do ultrasound in these cases, USG breast, right? Mammogram is done, ultrasound is done, right? Ultrasound or mammogram is done in these cases to detect breast carcinoma. Now, when we talk about the primary of bone mets, the most common tumors which metastasizes to brain in order of preference is, first is breast, next is prostate. The importance of prostate, maybe in future they might ask questions. They have osteoblastic mets, that is sclerotic mets, not lytic, sclerotic mets. This is important because a lot of times questions come in this. We'll come back to that. Prostate. Next organ involved is lung. So they might ask a sequential arrangement question in the future as well on this topic. Next is renal. and next is thyroid. These are the 5 tumors which metastasizes to bone. So in these cases, we perform bone scan as well. Within the bone, the most common sites involved are, most common site is spine. Why spine? Because in the spine, there is Batson's venous plexus. Batson's venous plexus is valveless. One of the important question, lot of times examiner is focusing on this aspect. Spine is one area where bone mets is seen. Apart from that, proximal femur can be seen as a metastatic area, or proximal humerus can also be seen as a metastatic area. So these are the most common sites. So in this woman, I would like to screen breast to find out the reason behind the osteolytic bone mets. Now next is cauda equina syndrome. Lot of times questions are coming on CMS exam. It's a repeat from general surgery. Cauda equina, spinal cord ends at the level of vertebrae T12 to L1. After its ending as a spinal cord, you have cauda equina nerve roots which are coming out. They have a cover of epineurium and perineurium. Sorry, they don't have cover of epineurium and perineurium. They only have endoneurium. There is no covering. That's why they are susceptible to compression. So in any lumbar disc herniation, cauda equina gets affected, and when it gets affected, usually it is in 25 to 45 years of age group people, they present with cauda equina syndrome, and the symptoms they develop are perineal numbness. Remember, perineal numbness. They have painless urinary retention, any urinary problem, or they will also have fecal incontinence. If you see any 40-year-old woman presenting to clinic with case of lumbar disc herniation, presenting with perineal numbness, painless urinary retention and fecal incontinence, it's an alarming sign. Urgently we have to refer the patient for MRI to check for cauda equina syndrome in all suspected cases. If there is a confirmation, we have to immediately go for surgical decompression. Which should be done within 24 hours. If not, they were left with some sequelae. So let's come back to the question. Which of the following statements are correct regarding cauda equina syndrome? Its presenting symptoms are perineal numbness, painless urinary retention and fecal incontinence, right? Urgent investigation is required, right? Most commonly no, not 45 to 60, it is 25 to 40. Now confirmed cases require early surgical decompression. This is also right. 1, 2 and 4 are right. So I would like to go for option 2 because option 3 is wrong in this case. Now next question is, which of the following are correct regarding late dumping? See, when we do peptic ulcer surgery, when we do for vagotomy, highly selective vagotomy, etc., it presents with a unique complication known as dumping syndrome. Now this dumping syndrome can occur early dumping syndrome. It can be a late dumping syndrome. So based on the differentiating features, I have seen a lot of questions these days coming in the MCQ entrance examinations. You need to know the difference between early and late. With regards to incidence, early is almost 5 to 10% of the cases, whereas late also 5% of the cases. Now presentation, how it is related to meals. Relation to meals. Dumping syndrome is also about diarrhea, development of diarrhea. Immediately after eating, in early dumping syndrome, you will see diarrhea. 2 hours or second hour after eating, you will see late dumping syndrome. Now attack lasts for, that is duration of the attack is 30 minutes. In case of early dumping syndrome, it is also 30 to 40 minutes. 30 to 40 minutes in both the cases, the duration of attack. Now how they get relief? The relief is by lying down in case of early dumping syndrome. The relief is actually by eating more food in case of late dumping syndrome. Now aggravating factors, as I said, it is aggravated by food. This is aggravated by exercise because food is a relieving factor here. Now precipitating factor, as I said, aggravating or precipitating factor, again it's food. Okay, precipitating factor is food. Here also precipitating factor is food. Aggravating factor is food, but here it is exercise. Relieving factor is food here. Here it is lying down. So based on these 3 points, I had seen many questions in the exam. Now symptoms wise, when I talk about early dumping syndrome, patient presents with epigastric fullness, patient presents with sweating, and they also have complaints like lightheadedness, tachycardia, and colicky type of diarrhea. Whereas what kind of symptoms do you see in case of late dumper syndrome? It is tremor. Patient will have faintness, tremors, faintness, and patient will have prostration. Okay, so now let's try to solve the question. Now, which of the following are correct regarding late dumping? It usually occurs during second hour of after meal, right? Second hour of after meal. It lasts for 30 to 40 minutes, right? Both these last for 30 to 40 minutes. I'm talking about late dumping here, not early dumping. Don't get confused in the exam. Now, major symptoms are tremor, faintness, prostration. I agree. It is relieved by lying down? No. It is relieving factor is food. Lying down is relieved by early dumping. So based on this table, they have asked this question. This is an important table given in Bailey and Love. The correct answer is 1, 2 and 3 here. The next question is, which of the following statement is correct regarding gastric outlet obstruction or GOO? Okay. See, in gastric outlet obstruction, what happens? If there is obstruction to the gastric, okay, there is vomiting. So this vomiting is more or less bilious vomiting. There is loss of chloride. Okay, HCl is lost, chloride is lost more. So patient will have hypochloremic metabolic acidosis. See, in general, metabolic alkalosis. In general, wherever there is alkalosis in the body, what should our kidney try to do? It should retain H plus, right? But you know what happens in this disease? When there is metabolic alkalosis, there is dehydration in these cases as well. This dehydration in turn causes little bit of hyponatremia. To combat hyponatremia, the body will retain sodium and it will lose H plus. To retain sodium, it will lose H plus. And it will lose K plus. So the patient will now develop hypokalemia and the patient will now develop paradoxical aciduria. What I'm trying to tell is, actually there is alkalosis. That means there is loss of chloride and bicarbonate already in the body. Right? Now, on top of that, there is hyponatremia. To combat that, we are losing acid also. Actually, when there is alkalosis, we have to retain acid, but we are losing acid. So that is paradoxical aciduria. So hypochloremic metabolic acidosis, paradoxical aciduria is characteristic of this gastric outlet obstruction. The metabolic effects seen in gastric outlet obstruction, right? Now, when there is alkalosis, there is so much of sodium bicarbonate. So body tries to lose sodium bicarbonate. In the process, it also loses sodium. So when sodium bicarbonate is lost, it causes hyponatremia. To retain that, the body will try to excrete potassium and hydrogen. That leads to hypokalemia and paradoxical aciduria. When there is alkalosis in the body, the alkalosis will cause tetany, because whenever there is alkalosis, calcium levels will come down and patient will have tetany. These are all the metabolic effects, and based on this metabolic effects, let me tell you, there's so many questions being asked in any entrance examination, and if you don't understand the concept behind it, you tend to confuse. Now, when I'm talking about gastric outlet obstruction, hypochloremic alkalosis is usual metabolic abnormality, right? Endoscopic biopsy is essential. Yes, it is very important. Medical therapy has no role in. No. You can give medical therapy in these cases of gastric outlet obstruction. You know, if you give aggressive medical therapy for peptic ulcer disease, it even leads to resolution also. That is, if you give PPI therapy for long, even gastric outlet obstruction clears. So there is role for metabolic therapy. Operation is frequently required along with a draining procedure. For benign diseases, if resectional surgery, if malignant, operation is frequently required. But no role is wrong. Has a role. So this is wrong. So the correct answer here is option 3. That means he is asking about which of the options is not correct. Sometimes students get confused between choosing whether correct or not correct part. Okay. So be very careful. Now, this is easy. The muscle relaxant with quickest onset of action and spontaneous recovery. Don't need to discuss. Succinylcholine, right? Succinylcholine is the quickest in action. Now, the first imaging modality of choice in 35-year-old lady presenting to surgical emergency with complaints of colicky pain. So, right lower quadrant pain. So, in a woman, right lower quadrant pain, that means you have to look at the ureter. It can be ureteric colic. You have to look at the fallopian tube, that is any genital problem. You have to look at the appendix as well, that is appendicitis. So all can be checked with the help of ultrasound abdomen and pelvis. The first investigation what we do is ultrasound abdomen. So my answer is option 3. Now Mallampati test, very easy. Mallampati test is used for assessment of airway. It will let you know if there is any difficult intubation. Okay, so there are 4 classes or grades in it. Complete visualization is class 1. Okay, if uvula is seen, class 2. If only partial is seen, it's class 4. Soft palate if not visible, only hard palate is visible, is class 4. So this is Mallampati score, very important. It's a frequent repeat in general surgery. Now consider the following: diabetes, hypertension, renal failure, jaundice. The question is, what are the risk factors for post-operative wound dehiscence? Okay, after the operation, why is wound dehiscing? It may be because of jaundice, it may be because of diabetes, it may be because of renal failure, but hypertension is nowhere related to wound part. So this is the odd one. This is the odd one. So 1, 2 and 4 are the correct options. Now if faced with a surgical emergency in a child of 15 years for whom no consent is available for life-saving surgery and no time for seeking authority from someone, the next step, see, you are going to save life. As a doctor, you have to perform surgery at a gunpoint, right? You have to perform the surgery, you have to save life. So we have a special doctrine for this in the BNS. Now we don't have IPS, okay, that is IPC. Now we have BNS for this, right? So BNS, Bharatiya Nyaya Sanhita, BNS section 19 says that if you are doing something as a necessity, we call it as a doctrine of necessity. Doctrine of necessity, BNS 19 doctrine of necessity says that you're doing something which will actually, in a good faith, is going to protect someone. So in this case, you're doing surgery on a child of 15-year-old in whom there is no one to give consent. So you're going to leave surgery. That's the reason, go ahead with surgery without consent as per doctrine of necessity. Okay. Now, which of the following information needs to be disclosed in order to establish valid consent? So you have to tell them about the condition and reasons why they need surgery. Yes. You have to tell them what is the type of surgery and what are the unexpected hazards of surgery. The surgical experience and expertise is not important. We'll never tell that surgeon is 10 years experience or 15 years experience. People are now advertising, but that is different, right? But while taking consent, the consent form will not contain the name of the surgeon or the profession or the experience. Okay, so this is wrong. So 1, 2, 3 are right answers. Now, a surgical department of a premier medical college conducted a study on rates of post-operative wound infection. The results of the study were negative. Even if the results are negative in any study, we have to publish them. Even if the results are negative, we have to publish them. What happens if you don't publish? Sometimes, if you are too picky about our results, okay, that will kind of put in a bias into the sample, right? It will put a bias into the sample. That's the reason there is no point in conducting a research, then leaving the research unreported. Even when results are negative, they are worth distributing. Under-reporting of negative outcomes, it causes systematic bias. So in this case, report the negative results is the right answer. Okay, there is a topic called surgical audit. Okay, basic principles of surgery, from where these questions are taken, and this is part of our syllabus. Okay, general surgery, it's included. These are not important for NEET, PG or INCT, but CMS will ask 1 or 2 questions in this area every year. Now, which of the following statements are correct regarding sutures in surgery? very big topic. I want to put this under the 10 question wala hard or difficult level. What is this barbed suture? You know, barbed suture has a loop. Nowadays we are doing laparoscopic surgery. During laparoscopic surgery, to tie a knot in the suture is difficult manually. If you take barbed suture, it will have an automatic, it will have a tie automatically. Okay, that is the importance of a barbed suture. It is mainly used in laparoscopic surgeries. See, there are four main type of suture techniques. One is interrupted suture. One is interrupted suture. Second one is continuous suture. Third one is mattress suture. You know, this mattress suture can be vertical or horizontal. Mattress sutures can be vertical. And we have a subcuticular suture. We'll start with subcuticular suture. Subcuticular suture is usually done where cosmetic appearance is important. That means we are not leaving any marks on the skin. See, under the burial technique we are doing it. Outside nothing is seen. It's too clean. So maybe plastic surgeons, they use most commonly on the face to avoid this, what we call this as cross-hatched markings, they call it as. To avoid this cross-hatched markings due to the suture, the cross-hatched markings, to avoid them due to the suture, we use subcuticular suturing. But we will not use silk for this reason, because silk is a silk has increased risk of tissue reaction and increased risk of infection. That's the reason for any cosmetic surgery, that too for subcuticular suturing, we will never use silk. We'll never use silk. Any degradable or non-degradable can be used, but silk cannot be used for subcuticular suturing. This is about subcuticular suture. Next, here mattress sutures can be vertical or horizontal. When I talk about mattress suture, they help in either production of eversion of wound or inversion of wound edge. Eversion of wound or inversion. Inversion is done by horizontal mattresses. Eversion of wound is done by vertical mattress sutures. Right? That's it. We have an Aberdeen knot. See, in continuous suture, we will do continuous suturing like this, but at the end we have to put one knot. So that knot, to close the continuous suture to avoid its slippage, is Aberdeen knot. Okay, these are the few points that you need to know to be able to solve this question. Okay, now let's try to look at this question from sutures in surgery. What they're trying to, which of the following statements are correct regarding sutures in surgery? Barbed sutures have advantage of eliminating the need for knots. Yes, that's what I told you. In laparoscopic surgery, if you use barbed suture, there's no need for knots. Vertical mattress sutures helps in eversion of wound. Horizontal mattress sutures helps in inversion of wound edges, right? Aberdeen knot is used for continuous suturing, right? Silk is preferred for subcut. No, silk is avoided because silk carries the risk of tissue reaction, infection, and it is not cosmetic. Usually we use silk for holding on to bags or catheters outside the body. Okay, it's not used for subcuticular suturing. This is wrong. So correct answer is 1, 2, and 3. Right? The commonest site of pressure sore, yes, it is ischium. We have asked this question in the mock test of our exam as well. There's a lot of questions which were repeat from our mock test of UPSC CMS. So many of the students after the exam, they messaged me saying that like we were able to find the exam familiar because they have solved some of the mock tests with us. So this question I have asked as a sequential correct sequence kind of question. So let's look at pressure source. Let's look at pressure source in decreasing or descending order of frequency. The top one is common location is ischium, followed by second one is greater trochanter, and the third one is sacrum, and the fourth one is heel, fifth one is lateral malleolus, sixth one is medial malleolus, and seventh one is occiput. Next year they might ask the same question with a sequential order kind of question. This year in UPSC CMS exam they haven't asked any sequential order question, but in previously they have asked. So the most common location is ischium, so ischium is the right answer. Now, resection of which part of intestine does not significantly affect fluid and electrolyte imbalance? Little controversial. I want to put it under the 10 questions which were controversial, but it's easy because ileal resection is dangerous. Colonic resection is dangerous because ileum and colon are the sites wherein fluid and electrolyte absorption occurs at maximum, right? So when we resect them, there would be a lot of consequences leading to short bowel syndrome. Short bowel syndrome. Even if you resect jejunum, ileum and colon has 90% retention capacity. So even if you resect jejunum, nothing much will happen. But in the Balian law, it's clearly given that the proximal jejunum, resection of proximal jejunum results in no significant alterations in fluid and electrolyte balance. See, actually, ideally, it can be proximal or distal because any jejunal resection has no effect. But because in Balian law, they have specifically given us proximal jejunum, let's go with option 2. Right? Then. Good measure of systemic perfusion by ABG. When you do ABG, see, there is a case of shock. You are giving treatment. The first thing you do is you check for urine output. Because urine output is the best way to check for how well patient is responding. Urine output is one of the best measure to check for the fluid, whether it is going in the correct way or not. So the best measure of organ perfusion or the best measure of organ, it's a previous year question, doc. Best measure of organ perfusion and best monitor of adequacy of shock therapy. Remember this. This is important. These two are urine output. Done. But problem with urine output is you have to do it hourly. Minute to minute is not possible, right? If you want to check for cerebral perfusion or brain perfusion, if you want to know, then you check for conscious levels, the consciousness. This is clinical parameter, that is consciousness. But if you want to check for perfusion of systemic, I'm not talking about organ, but systemic organs. So then we go for ABG analysis and we check for serum lactate levels or base deficit level. Okay, so in this question, the answer is lactate or base deficit. Okay, right? Systemic perfusion, I'm not talking about organ. In general, systemic perfusion I'm talking about is base deficit, lactate, and one more parameter is there which is not given here, mixed venous saturation. So these are the three parameters that we use for systemic perfusion. Cerebral perfusion is consciousness, organ perfusion and best monitor of adequacy of shock therapy is urine output. All these three are important questions. Now, which of the following are congenital abnormalities of the gallbladder? Phrygian cap, you know. So this is how Phrygian cap looks, common question. So this is one. Absence of gallbladder is one. Floating of gallbladder because of mesentery which leads to torsion of gallbladder is also one. Spigelian hernia is there. Spigelian hernia contains intestinal contents. One of the content can be gallbladder, which is very rare. But this is not gallbladder congenital abnormality. It is because of the defect in the anterior abdominal wall, that is Spigelian hernia. So this is wrong. So the correct answer here is 1, 2, 3. Now, which of the following are functions of gallbladder? See, liver synthesizes bile. It secretes bile. So if this is liver, okay, the bile, and you have gallbladder. Now when patient is fasting and all, the bile will store here. So storage of bile, concentration of the bile, that is reservoir of the bile, is gallbladder. It's not synthesis or secretion. So this production, that is, this is wrong. Apart from storage and concentration, it also helps in secretion of mucus. So this is right. So 1, 3 and 4 are the correct options. Which one of the following statement is right regarding Budd-Chiari syndrome? It principally affects young males? No, young females. Venous drainage of liver is occluded by IVC? No, hepatic vein thrombus. Quadrate lobe enlargement? No, it is not quadrate lobe, it is caudate lobe enlargement, right? Lobe 1, this is segment 1. Abdominal discomfort and ascites are presenting features. This is easy. So option 4 is correct answer. Which of the following is correct regarding splenic artery? Very rare question. I want to put it under that 10 question column, which are very hard. Nobody reads about splenic artery aneurysms, right? But when I talk about splenic artery aneurysm, uh, see, there are many conditions in clinical practice which are more common in females. When they are common in females, then only they'll ask this question. So this is wrong. It is common in women. It is situated in main arterial trunk. Yes. It is caused due to trauma. No, it is not because of trauma you see aneurysms. Aneurysms are because of sepsis. It is generally multiple in number. No, these are solitary lesions or single lesions, very rarely multiple. So the correct answer here is it is usually situated in the main arterial trunk. A little bit tricky question to answer. Now, which of the following statements are correct regarding primary survey? See, during any traumatic head injury or RTA, we go for primary survey and secondary survey. In primary survey, mainly we make sure that we have C, A, B, C, D, E, F, right? A means airway. Okay, we have breathing, circulation, disability, etc. Right? A, B, C, D, and now in secondary survey we check for head injuries, further injuries, pelvic injuries, etc., spine injuries, etc. Now in the primary survey we have to make sure that there is adequate oxygenation and circulation, and we have to check the pupil size and response, because disability are stated, we go for Glasgow Coma Scale also. We have to exclude hypoglycemia as well, but we will never check for mechanism of injury here. Mechanism of injury is checked in the secondary survey. This is wrong. So 1, 2 and 4 are correct answers. 1, 2 and 4, that is option 3. Now A, B, C, D, E, the primary spread of trauma is: A is airway, B means breathing and ventilation, C is circulation, and hemorrhage. Okay, this is not control of massive external hemorrhage. There is new parameter called C, A, B, C, D, E. So this C, small c, not capital C, small c stands for control of massive external hemorrhage. So this is wrong. D stands for neurological status. A, D, 1, 2 and 4. So the correct answer is option 3. Which of the following statements are correct regarding inguinal hernias in children? See, the specificity here is that inguinal hernias are because of the persistent processus vaginalis in children. Okay, the problem is the same persistent process vaginalis will also manifest as hydrocele. So that's the reason in adults inguinal hernias are not transilluminant, but in children they are transilluminant. So they're frequently transilluminant. This is right. It is always indirect because of the persistent processus vaginalis. It is more common in preterms, not full term boys. It is more common in preterms. It should be repaired promptly. Yes. 2, 3 and 4 are the right answers here. Right, so this will conclude our general surgery discussion. So PSM, OBG and general medicines are gonna come in short time. So do comment about how you felt about this discussion. The more detailed discussion along with PYQs with explanations and all the notes will be provided along with the CMS course now, which is live for 2026. If you like our pattern of teaching, if you like our way of understanding the depth of UPSC CMS exam, and if you're very serious about becoming a CMS medical officer, okay, you can check our website UPSC MEDICO. Okay, the course is live there. You can start your journey for 2026 exam. All the best.